So she's in this conundrum where she has to sort of decide, which should I do? Now, if we reach out to her and say to her in English, in a way that doesn't take into account the situation I just described about her, she doesn't have transportation. She's not going to get paid if she takes time off from work. She's got 3 other kids. She's got to figure out what to do with them. If we send her a generic message that was written for a traditional English speaker, just translate it into Spanish and send it to her, that message, when she gets it, she's going to say, this message wasn't meant for me. They don't understand my situation. They don't care who I am.
And now, from San Francisco and the UCSF Rosenman Institute, the Health Technology Podcast with your host, Christine Winoto.
Our guest today is Abner Mason, founder and CEO of ConsejoSano. Today we'll talk about the changing demographic in the U.S. and how our healthcare systems have not completely kept up with it. ConsejoSano is bringing a solution and approach so more people can have a better access to care in this country. A little background about Abner. Prior to his starting ConsejoSano, Abner founded and led the Workplace Wellness Council of Mexico. Today, it is the leading workplace wellness company in Mexico. He's also appointed by President George Bush to be the chairman of the International Subcommittee in Developing Policy to ensure effective U.S. leadership in the global fight against HIV. I hope you enjoy our conversation, and if you like what you heard, please subscribe to this podcast on your favorite app. Well, thank you, Abner, for joining me today. It's been a crazy year, isn't it?
Definitely. Like no other.
I just thought that I think 2020 started off really, everybody was so bullish about the whole things. And I think sometimes life, gives you lemon and you just need to figure it out. And how are you doing and how's the company doing during this shelter in play?
So me personally, I'm doing well. It's been since mid-March, so I definitely am getting anxious to do more things outside of the house. We had the whole office, all of our employees, including me, went to working from home in mid-March, and so we've had to learn how to be productive in that environment. And I'm really glad the team is more productive. Interestingly, more productive working from home than they were in the office. So and they like it more. In fact, recently, just in the last few weeks, I asked our team members on one of our team calls who wants to go back to the office, and no one said anything. So no one raised their hand to say, I want to go back to the office. So we're more productive than we ever were. The team members are happy. They don't want to go back to the office. So it's going to be kind of interesting when we have to figure out how to navigate that issue right now because of the spikes we're seeing in infections in California and Southern California as well. There's definitely no reason to rush back to the office. But at some point, we're going to have to make that decision. But for now, to answer your question, we are being incredibly productive and a little stir crazy. So I'm doing things like going for a walk, a long walk every day to get out of the house. But overall, things are good.
Well, that's good. I think it's amazing how going out for a long walk keep our sanity.
It makes a big difference.
Yeah. In check. I'm so glad that we also live in an area that weather is pretty nice too for a walk.
Yeah, I'm a little concerned about some parts of the country. If we do have a true second wave and people are actually in their homes, but weather is going to prevent them, like back east where, I spent a lot of time in Boston, you can't go for long walks in the winter. It could really, people could really get stir crazy.
Yeah. No, let's hope that did not happen. Yes. That doesn't happen. So, yeah. But so you, like you said, you're how big is your team now?
We are about 45 people full time. Most of those folks are here in the Los Angeles area, which is where our headquarters are. But we do have some team members, a couple people in Boston, and one person in New York, and one person in Utah. But otherwise, so almost everyone is here in Los Angeles, in the greater Los Angeles area.
it's amazing how you're saying that everybody adapts really well to this new way of working, and technology helps as well.
Oh yeah, no question. What we're doing now, Zoom really helps. This may not be as big a factor in some parts of the country as it is here in Los Angeles, but our team members spend a lot of time commuting. So one of the benefits of working from home, I've got team members it was a 50-minute commute each way. So if you think about gaining, almost 2 hours to your day, and you don't have to fight with traffic for almost 2 hours. It's not like the commute is a pleasant, lovely experience where you don't have to think about anything. So, for a lot of our team members, it really has changed the quality of their life, the quality of their day in a much better way. So, I think that's one of the reasons why you're going to see a lot of companies, and ours is probably going to be one of them, where we're not going to go back 100%. We may, we got to figure it out, but I know pretty certain we won't go back 100%.
Yeah. So I think maybe that's, because, it's not every company can have the employee work from home, because depending on the type of work that they do, maybe this is a good segue for you to tell us what is your company is doing. ConsejoSano. Is that how you say, how to pronounce it?
Yeah, ConsejoSano. So it means healthy advice in Spanish. And we are a patient engagement and patient navigation company. So what we do is we work with most often health plans and sometimes providers or provider groups. We help them to engage with their members or their patients in order to get those members and patients to do certain things that are important in terms of helping them to stay healthy. So, for instance, a lot of our clients are in the Medicaid space. We have a big footprint in Medicaid. So we work with the Medicaid managed care plan that is responsible for managing the health benefit for the beneficiaries. For a lot of Medicaid plans, managed care plans, they might have 100,000 members or 1 million members. Or more in some cases, 2, 3, 4 million members, depending on the state and the size of the contract that they've won. Their job, their responsibility as the plan for those beneficiaries is to engage them and to get those beneficiaries to do certain things. For instance, children need to have an annual wellness visit. So that mother or father or grandmother, whoever's responsible for that 3-year-old, that 4-year-old, that 5-year-old, has to bring them in for an annual wellness visit. Babies, from the time they're born to the time they're 2, so 24 months of life, that first 24 months, they need 10 vaccinations. It's called the Combo 10. Someone who's responsible for that baby, mom, dad, grandmother, whoever it is, has to bring that baby in to get a vaccination. These are all required activities in the Medicaid program. So if you're the plan and you've got 1 million members, and those members come from a wide range of cultures and languages and backgrounds and experiences. They're all low income because it's Medicaid. So many of them have some of the social determinants that prevent them from coming in. The plan needs help to engage and get those members to build a relationship with them and then to navigate them into care. And that's why they reach out to us, ConsejoSano. We have perfected, I would say, but we're very good at engaging hard to reach, multicultural, low income members of patients, and then building a relationship and navigating them into care. That's what ConsejoSano does.
So the example that you're telling us about, like that the children that need to get the vaccination, is that because the plan, if these children don't come, then they don't get paid by the government? Is that what is the incentive for them to make sure that members getting their care?
Exactly. So why does the plan feel so obligated to make sure that 3-year-old gets that well child visit is your question.
Yes.
And it's because the plan has a contract with the state. Medicaid, as you know, is a state federal program. So the federal government pays for part of it. The state picks up the rest of it. But the way the program is designed is different in each state. Each state has the right to design their Medicaid program. And in partnership with the federal government, there are certain requirements that are put on the plans who win through contracts, win the ability to manage the care of a given population in a given state. And so the plans compete to win these contracts. It's typically some sort of RFP process, and it's very lucrative. Lots of money involved. The annual spend for Medicaid is about $700 billion with a B dollars. California alone spends $100 billion with a B a year on Medicaid. So as you can imagine, these are huge contracts that these managed Medicaid plans fight to win, and they want to keep them. And so what the state does in conjunction with the federal government, they set up guidelines or goals for the plan. And they say, basically, every child that's 3 years old that you now are being paid to cover and provide the benefit for, you have to get a certain percentage of those children in for that wellness visit. And if you fall below a certain percentage, you'll start to get penalized financially. And if you really get below a certain percentage, we can cancel the contract, or we can prevent you from participating in the next bid. So there are significant penalties for plans if they don't figure out a way to engage that mom or that dad or that grandmother, who's ever in charge of that 3-year-old, and that person, that mom or dad, they don't particularly. They don't like the plans. Sometimes they don't understand healthcare. There may be trust issues with healthcare in the U.S. English may not be their first language. There may be cultural issues. There may be issues like no transportation to go to the appointment. There's all sorts of barriers that are in the way of that 3-year-old. Someone bringing him or her into the clinic for that well child visit. So the plan is on the hook. They have to get it done, but there's a lot of things that have to happen to get it done, right? You got to get a lot of pieces to fall into place, and the plans just really struggle to do that. It's hard for them because they're doing it. They're responsible for, as I said, hundreds of thousands of millions of beneficiaries, and so they need help, especially when those beneficiaries are multicultural, when English isn't their first language, or when cultural traditions that they have make it hard for the plan to reach out to them. And so they hire us to help them to connect with that member.
So I think what you guys are doing actually is really amazing. I'd like to hear more. I mean, because over time people have said, well, why can't you just translate the language to whatever language that is? But I felt what you guys are doing is beyond just language.
Right. So, if you're trying to convince someone to bring their 3-year-old in, and that young mother, let's say a young mother, and maybe she's Hispanic, and she works, and so she's got a job that she doesn't get time off to bring the child in. If she takes time off and she doesn't get paid, and she doesn't have transportation, she doesn't have a car because she's low income, and she has to use public transportation. So for her to bring the child in, that 3-year-old, for a wellness visit, it means 2 bus rides to the clinic, then the time in the clinic, and then 2 bus rides back. She loses a whole day of work. And this is a very real instance. If she's living paycheck to paycheck, so she's able to just pay rent and get food for her kids, because she's got 3 other kids plus that 3-year-old. She's got 4 kids total. She's able to make just enough money from her job to cover her expenses, to keep a roof over their head and food. So she has to decide, if I'm going to take a day off, I'm not going to get paid for it. And in fact, I'm not going to get paid. Some employers will say, if you take the day off, don't come back, because there's somebody else who we can hire to replace you. We're not paying you to take care of your kids. We're paying you to do the job. So you decide what's more important to you, taking care of your kids or the job. So she either doesn't get paid for the day, or she potentially could lose her job. But either way, she's got to make a choice. Do I take my kid in, this 3-year-old, for an annual wellness visit that, the child is fine, he's healthy, he's not, there's nothing wrong with him. But we know that there could be things that she can't see. That's why you have a wellness visit, right? And it's particularly important for children to have a wellness visit. So she's in this conundrum where she has to sort of decide, which should I do? Now, if we reach out to her and say to her in English, in a way that doesn't take into account the situation I just described about her, she doesn't have transportation, she's not going to get paid if she takes time off from work. She's got 3 other kids. She's got to figure out what to do with them. If we send her a generic message that was written for a traditional English speaker, just translated into Spanish, and send it to her, that message, when she gets it, she's going to say, this message wasn't meant for me. They don't understand my situation. They don't care who I am. They haven't taken the time to figure out who I am. They don't know anything about me. And I'm not anxious to engage with people who don't know me, who don't care to know me, and who don't even try to understand my situation. And so what we believe is that what's happening today across healthcare is that sort of one size fits all approach. They take a message, you need to bring the baby in for a well child visit. And yes, they translate it into Spanish, but they send her that message. And we're treating her like who she is doesn't matter. Like her situation it doesn't matter. Like she doesn't have all these factors in her life. And so what we say to ConsejoSano is that old approach of one size fits all with, you translate it, but it's still the same message translated. We don't think that works. And so what we're saying is we can use data to find out more about her, and we can send her a message that was meant for her that says to her, oh, and by the way, if you don't have a ride, here is a transportation benefit. Oh, and by the way, if you can't get time off of work, the clinic is open on Saturdays, and we can arrange for you to go on Saturday and have transportation. We can take into account who she is and then communicate with her based on that. And what we found at ConsejoSano is that if you treat people like who they are matters, like what's going on in their life is important, you will get higher engagement. You'll actually get her to engage with you. And that's what we're doing. And we're using technology to do that at scale. We're serving about 1.5 million people today. We want to grow our business to be serving, 5 million people in a few years. But the key is not getting away from this idea that who people are matters. And you really have to kind of as a value at a company, you have to say, I'm going to, from now on, treat people like who they are matters. I'm not going to treat them like they're a number or like they're all the same. I'm going to treat them like they're special, like they are somebody. And we found that when you do that, you can just get much better outcomes.
Yeah, I think we all human, they like to, as a person, we like to be acknowledged what our challenges are rather than just number. So how, as a company, how do you use technology and to better understand the population of the member?
Yeah, that's a really good question. So how do we do it? It really is all about data. And it's not, the idea is not rocket science. Other parts of our economy have figured this out already. So like, I like Netflix. I have Netflix, and if I watch a certain movie or TV show, they have already built algorithms at Netflix that all of a sudden they'll start to recommend additional movies or other shows that they think I'll like. And by the time I've watched 3 or 4 things, they've got it down. They know exactly what I like. And they're introducing me to things, to shows and movies that I never thought I would have liked. It's interesting. They know me better than me. Like I wouldn't have picked it. But I look at it and I'm like, they were right. This is really good. This is what I like. And Amazon is the same way. If you buy, I challenge you to buy a pair of shoes online and wait to see what happens.
I know.
They'll start to recommend shoes for you. And by the time you buy a few shoes, all of a sudden they know exactly kind of your style and who you are, and they'll start to recommend things. But that whole approach of using data and algorithms to understand who a person is, and then to start to treat them in a different way that's unique to them. As I said, it's happening all across the rest of the economy. Healthcare is just woefully behind. So what we're doing at ConsejoSano is not in the sense rocket science. We're not, in a sense, a blazing new territory. We're just saying let's bring healthcare from the 1970s into 2020, and that means using data, public data, private data, claims data. We have built a technology platform that allows us to ingest an enormous amount of data about a given member or patient. And then we add to that a team that we built we hire people from the communities they're trying to serve. They have, many of them have been on, for instance, Medicaid before, because we do a lot of Medicaid business. They come from the cultures and the languages that we're trying to engage. So we add to all of that data a deep understanding of how people engage in healthcare in the communities we serve. And the combination of the technology and that human touch allows us to engage with people in a way that builds trust. They are willing to listen to us. And interestingly, not just listen, they're willing to share with us what's happening in their lives. Because a lot of times what happens is that if you don't have a trusted relationship, people might not tell you that I don't have transportation to get to my appointment. They just won't show up. They just don't show up. And so you've got to have a trusted enough relationship that patient or that member is willing to say to you, to share with you, I don't have a car. And a lot of communities, there's a certain, we're all human. We're all, in that sense, we're all the same. There's pride. There's a sense of self-worth. And people aren't eager to tell you, for instance, I don't have the money for public transportation. So I don't have a car, but there is a bus, but I don't have the money. People will not tell you that unless you have built a trusted relationship with them and they're willing to share with you. So we really believe that approach of building that trusted relationship based on data allows us to then engage that member in a way that others have not been able to.
So in addition to data, and do you think having a diverse group of a team and staff, does it help to understand your population better?
Oh, dramatically so, because the data helps us to understand who that member is, but you need to combine that with a sort of a human approach to like creating content. So a lot of what we do is via text message. We find that text message, particularly two-way text messaging, is a really powerful tool to engage people. So the data tells us what we want to say, how we should engage, but actually designing that text message and making it fit in a text message format in the right language and in the right culture. None of the technology tools today do that. They do a hard translation, but it comes out and it makes no sense. So you can use Google Translate, and I love Google, nothing against Google, but you can't use Google Translate for this purpose.
Right.
It doesn't make sense. And so to your point, we built a team of people. I think we cover about 20 different cultures and languages on our team. These are people who come from these cultures. Many of them are first generation Americans. They understand the experience of the people that we're trying to engage. And they have this thing, the word for it is simple, but it is not something that's simple. It's called empathy. And how being empathetic is so central to being able to build a trusted relationship, but it's hard to teach. I'm not saying it's impossible to teach, but what we found is you're better off finding people who have that empathy, who in the way they've lived their own lives and their own experience, it's taught them to be empathetic to others. And that's what we do when we hire. I'd love to be able to figure out a way to teach that. We haven't quite figured that out yet. But what we do is we focus on finding people who have empathy. And to your point, that's, again, not something that we can hardwire now and just press a button and create content that's empathetic. You have to, we don't have that ability. And then the other quick thing why we call these people care coordinators. That's the title for them on our team. Is because although much of what we do is with text message back and forth, and a lot of it's automated, and we're trying to get more and more of it automated as a business, it makes sense for us to try to get as automated as we can. There are situations that require a real person to step in. Healthcare is just not, I don't think we're at a point now, and I doubt we will be for a very long time, when it can be done completely without a human interaction. We can do a lot, and at ConsejoSano, we're doing a lot more because we're getting better and better at the automated, but we still have the possibility of kicking a conversation out of an automated queue and having a real person get on the line with that member or that patient, because sometimes you need a real human being to connect with someone. If it's not often, and it's by exception, but it is important.
Yeah, and I think it's interesting. I like to think that humans are pretty universal, but then because of different background and culture, sometimes we react differently.
Completely right, and you're exactly right. And unwillingness to recognize those differences, and not just to recognize them, but to actually honor them. I think that this is what makes us special as humans. It's who we are, and we ought to not. We shouldn't ignore it. We shouldn't push it to the side. We shouldn't acknowledge it, but then don't do anything to show that we know it's important. I think we actually have to take steps to engage people and to honor that difference. And when you do, and what we found is when you do that, when you take the time to do it, and we've found a way to do it in an economically, effective way, you can get dramatically higher engagement.
Mm-hmm.
And because you're building trust with people, right?
Right.
It's a trusted relationship. They feel like they're not just a number, that that you don't think that who they are is unimportant, and that you care about things that are happening in their lives. Because a lot of the things that prevent people from seeking healthcare access aren't directly healthcare related. As you know, the social determinants are really important. But as I said before, getting to the point where you have a trust enough relationship that people will share with you what those factors are is no easy thing. And I'm just going to tell you, health plans typically aren't where people go when they want help, but they don't have food for that week.
Right.
They think of their health plan. But health plans are increasingly realizing that if they can't help solve that problem for the member, no food in the house, talking about a well child visit is not going to be very effective. And to their credit, plans are realizing that, and they're saying, okay, we understand that, and so is the federal government. There's a lot of emphasis on now addressing social determinants, but what people are forgetting is that there's that human component, that people aren't going to share those aspects of their lives with people they don't trust and people who they think don't care about them. And so you gotta show you care, and that creates the trust, and then you can engage in that kind of conversation.
Yeah, that's really interesting, because I think oftentimes when people think about technology, medical technology, we don't think so much about working so closely with the patient, right. But where you're like the bridge, right, between the plan and the patient population.
This podcast is sponsored by Brown Rudnick's Global Life Sciences Group, a team of legal professionals that help life science companies, lenders, and investors around the world turn good science into good business. Learn more at brownrudnick.com. This podcast is also sponsored by Canon Quality Group. Canon Quality Group has been helping medtech startups set up quality management systems for over 10 years. If you're unsure when to get started with quality management in your startup, turn to the experts at canonqualitygroup.com.
And one last question about in the business side, because I'd like to know your story, how because you have really interesting background, because you did not start it out doing something in healthcare. Yeah, here you are. I often hear about, Medicaid business. Everybody kind of always, people who don't know, they feel like, oh, I don't know how can you they can make economic sense to be in that space. Yet you are successful in tapping in that particular areas that needs so much technology.
Yeah, I think that in the past there was this view that the Medicaid program is the program for low income people, and just that alone brought a bit of kind of an unwillingness of investors and technology innovators to say, is that the place for me with poor people? And I'm just being honest that there is that kind of a bias that existed for a long time with Medicaid. But I think that two things have happened in recent years. One is that the Medicaid program has grown so dramatically. It's we're talking about 74 million Americans today, almost a third. And given the current economic situation, there's an expectation from some experts that we could hit 85, 90 million folks on Medicaid. So it is the largest health plan in the country. More people are on Medicaid than are in the whole country of France, for example. So we're talking about a big health program that has only grown recently. So I think that's one factor, that just the size of the program. And as I said, the spend $700 billion a year. It's foolish for investors and others not to look at this program because of the size of both of the number of people who are affected and the spend, the annual spend on it. And then I think that because it has grown so much, there's a willingness now on the part of all of the sort of decision makers and the stakeholders in the Medicaid program to say the kind of growth in cost hitting 700 billion, and people are talking about 800 billion, and we have got to find ways to deliver high quality care more cost effectively. Both in terms of better solutions for patients that improve their health, but also they're more cost effective. And so that pressure to find solutions that work, innovative solutions, has, I think, opened the door for investors and innovators to say, wait a minute, there's a huge opportunity here if we can figure out a way to do it better. And frankly, the way it's done now is not the best. We're not getting the best results. We're spending a lot of money and we're not getting great results. And so there's a huge opportunity. So I think that has also, in the last few years, caused a lot of folks to look at Medicaid with new eyes. They're Before they used to say, oh, that's the poor people. And now they're saying, wait a minute, that's the third of the country. Right. And that's the biggest health plan in the country. And if we're into innovation and finding new solutions, there's nowhere better than in the Medicaid space. And then the last piece I'd say is that as the program has grown in cost, regulators are putting pressure on plans to do better. Most of Medicaid in the country now is managed care, meaning almost all of the states, with a few exceptions, have moved to managed care, which means that the state doesn't directly manage the benefit. They contract out to these plans, the managed care plans, and they manage the benefit. But the states are putting major pressure on the plans to do better, to be more effective, to make every dollar stretch further. So you have the plans now interested in innovation in a way that they weren't before. So all of that together, I think, has made Medicaid more attractive to investors and to innovators.
When you started ConsejoSano, did you find it challenging? Because at that time, people has not picked it up, but you're successful in getting the funding from the right people.
Yeah, definitely. It's funny, when I was first starting and raising money from investors, a lot of VCs or venture capitalists, I would go in and I would talk to them about Medicaid, and they would say, they would immediately start to talk about how the demographics were changing, but they meant age. They didn't know the difference between Medicaid and Medicare. And so they were thinking, the baby boomers are all going to become seniors, and Medicare Advantage is going to be a big opportunity. And I say, wait. I do care about Medicare Advantage, and we actually do work in that space. But I was talking about Medicaid, and they were like, Medicaid. So a lot of VCs in the early days, when I was raising, certainly, it happened many times, not just once or twice. They didn't know about the Medicaid program, because a lot of VCs, and this is, I'm not being critical, I'm just saying a fact, they have in their lives not been on Medicaid. They've not been low income, or it's been so long since they were low income that they don't. It's not something that comes to mind for them. And so when you're talking about a program for the low income Americans, they didn't understand it. They didn't know. And so I literally talked to some VCs and I say, do you know anybody on Medicaid? Anyone? And they'd say no. I mean, think about that. And, I'm not being, I sound like I'm being critical, and I'm not. I'm just making an observation that
it's the reality.
It's a reality. And we only can, we are who we are. We grew up the way we grew up, and we have certain backgrounds that we come from. We can't change that about ourselves, because it is who we are. But I do think what needs to happen, in a small way it has happened with Medicaid, we need to not, going forward, we need to broaden our horizons. It doesn't matter how you got to where you are today, and maybe your background didn't, cause you to interact with a lot of low-income people. But my view is, if you care about healthcare in America going forward, you got to broaden your way of thinking, because the Medicaid program, and low-income people in particular, are crucial to this country's future. And so when it comes to healthcare, and the country generally. So I've encouraged, I think it's a good thing that VCs are now being a bit more broad and willing to get beyond their own background, and to see that it's big, and if they want to have a profound impact, both financially and in terms of improving healthcare, they got to think a bit broader.
Yeah. So I think maybe this is a perfect segue for me to learn more about your story. You were working in the private sector, you were doing policy in the government, and then become CEO, and then you were doing in the AIDS and then in Mexico. Tell us more about how you end up where you are today.
Sure.
Why you chose, where do you grow up as well? From any of your parents are in this space?
Yeah, my mom and dad, my mother was a licensed practical nurse. An LPN was the term at the time. And my father was not in healthcare. I grew up in Durham, North Carolina. Lower income family, although I didn't know it at the time because my parents made sure we had what we needed. I didn't know we were lower income till I left and found out that there are people who had a lot more than we did.
Okay. That's the beauty of being kids.
Exactly. It's the beauty of being a kid. And my parents were great about, giving us certainly everything we needed. And then some of the things that, a few of the things we wanted, it was good. I ended up getting a scholarship to go to a prep school in Massachusetts. So this prep school was interested in helping lower income kids. And so I got a full scholarship for 3 years to Governor's Academy in Massachusetts. So I left Durham and at the end of the 9th grade, I went to, I think I was 14, and went to Massachusetts to a boarding school. And it was a mind-blowing experience.
That must be a culture shock.
Talk about culture shock, like nothing, everything was a culture shock. From all of the other kids at my school were for the most part very wealthy. The tuition was very expensive. They gave me a scholarship, but everybody else was paying for the most part. So wealthy kids, primarily white. It had gone to co-ed, so we did have boys and girls, although it had been a boys' school for a long time. And the weather, my first year there was a huge snowstorm like I had never seen before in my life that shut down the state for a week. So in every way, it was like a culture shock. But I loved it. I was there for 3 years. I did 10th, 11th, and 12th. And then I went to Harvard after that. And that was also an incredible experience. I loved it and met lots of interesting people there. And that opened my mind to in a lot of different ways. And then my first job was at Bain Company. It's a strategy consulting firm.
I always thought that, I never know about consulting firm until I was in business school.
Yeah.
I don't know whether that was your dream to be working for Bain.
No, it was like, to be honest, I was a senior. I didn't know what I wanted to do. I had studied physical sciences and philosophy. So I was, in my mind, prepared to do anything, but actually knew nothing that would actually make me useful to someone with a job. And so at that time, and I think it's still the case, a lot of the consulting firms and investment banks would come to campus and recruit. And so Bain came, and so they offered me a job, and I couldn't believe that they offered me a job. I was like, I don't know anything about business, but they had this sort of boot camp where it was like a mini business school for people like me that they put us through, and it taught us the Bain approach to analyzing businesses. And so I loved that. It was interesting. And around that time, I ended up supporting a guy who was running for governor of Massachusetts, and he ended up winning. And he said, "Look, I need new ideas in government, Massachusetts. Come in just for 2 years. Give me just 2 years." And I really believed in him. There's a guy named Bill Weld, who actually has been in the news recently as well. But I went into state government. Was supposed to be 2 years in Massachusetts, and it ended up being almost 12 years. I was in state government. I held a number of roles and ended up being a chief policy advisor for 2 governors. And that was a great experience. And I learned a lot about all of the issues that governors face, but particularly healthcare. Massachusetts was the first state to have universal healthcare. So I did a lot of work in the lead up to that. It actually happened under Mitt Romney, who became governor after I left state government. But I learned a lot. And during the time in state government, I got appointed to the Presidential Advisory Council on HIV and AIDS. And I just loved that work. And that's during the time when the President George W. Bush announced this huge initiative called PEPFAR, the President's Emergency Plan for AIDS Relief. And I was chair by then of the International Committee for the Presidential Advisory Council. So I did a lot of work in the lead up to PEPFAR, and I just loved that work. And one of the things we did was we went to Africa and looked at the impact of some of the U.S. funding, USAID's funding in some of the poorest countries, particularly I spent time in Uganda. And it changed my life in a sense, because I saw in Uganda, and particularly in rural Uganda, this is the part of the country where there's no running water, there's no electricity, there's no paved roads. And yet we, the U.S. government, through a program funded through the CDC at the time, was able to provide antiretroviral therapy, a pretty complicated therapy, to hundreds of thousands of people and ultimately millions of Africans through the PEPFAR program. And when I saw that we could do that in the poorest setting and some of the poorest settings on earth, it really changed my view about healthcare and what we ought to expect and not be willing to settle for less in the U.S. If we can do that in Africa with no one in rows, none of the infrastructure was there to deliver a complicated therapy. We certainly ought to be able to make decent healthcare available to people in Philadelphia and in L.A. and in New York and across America. So when I left state government, I started a nonprofit that focused on HIV/AIDS, and we did some incredible work in Mexico. We built the first business council on HIV/AIDS in Mexico. And then that led me to cross over to the for-profit world. We created a company in Mexico that helped companies in Mexico to improve employee health by implementing wellness programs. And that's when I had the idea for ConsejoSano, because I was working in Mexico, seeing how the mobile phone was being used and how the mobile phone was being being used by the growing middle class in Mexico to expand access to healthcare, high quality healthcare. And I thought, if we could do this in the U.S., we could solve one of the big problems here, which is that our country's become more multicultural, but our healthcare system, even though it has many good qualities, it is not equipped to serve the America that we've become today. We're a different country than we were in 1970, but our healthcare system, while it has had technology advances, its ability to engage a multicultural population hasn't kept up with the demographic changes. And I thought we could be part of bridging that gap. And that's really what ConsejoSano is doing. If you think about it, take a step back, we're trying to help bridge the gap between a health system that's not equipped to serve the population as it's changed and continues to change. We want to be that bridge and help make access work for everybody. And when I say everybody, I mean everybody who calls this country home. So I don't make a distinction between rich and poor, black and white, or documented and undocumented. I think anybody who calls this country home, we're a wealthy enough country that we ought to be able to provide decent health care to everyone who lives here.
I agree. It's interesting because you were working for government for a long time, actually.
Yeah.
And not that many people I know when they work for a government. I mean, I grew up in Indonesia, where once you work for a government, you stay in government for the rest of your life. Probably it's slightly different here in the US, but even here, probably people, once you work for 12 years in one place, usually you have less desire to go to somewhere else, but you keep exploring.
I guess I'm not. I started in the private sector with Bain Company doing consulting. Then I went to government, and I loved that work. I really think we made a difference, and I think that government is an important, important stakeholder in our country in terms of improving the lives of Americans. But then I left government and I created a nonprofit. So I was in the NGO nonprofit world for quite a while, running a nonprofit, and then I crossed over and started a for-profit, and then ConsejoSano. So I kind of feel like I have.
It's almost like you planned this career to do ConsejoSano.
It's a funny thing about life sometimes, that when you look back, you can see the thread and the plan, and it looks like a plan, but there definitely was not. I wish I could take credit for it. There was not at all a plan. But here's what I do think. I think if you are willing to be a learner, that no matter what situation you're in, if you are willing to absorb everything you can learn and to be humble, as opposed to trying to think you know everything, is the opposite, to sort of take the view that I can learn a lot in this situation. I think that's the thread that has helped me, because there's no question running ConsejoSano, an early stage venture backed company, we've had a lot of success. I still have a lot to do. We still got a lot of goals that we want to hit. But we built a company. We've got a great team. We've raised money. One time we're looking to raise a Series B as well. We've got a brand in the marketplace that's well respected. We have clients now across 12 states, and soon that's going to grow dramatically. We have contracts with the biggest health plans in the country. We've really been successful, but I am absolutely certain that a lot of that success has come from things I've learned in these other areas. I brought those learnings along, and they've both helped me solve problems in the present. But the other thing they've done is they've made me really humble about how much I don't know, and I think that's a good way to be, because it allows you to learn.
Yeah, and I learned that I think the more somebody knows, usually the humbler they don't realize that they know so much more. And I think the people who usually are so full of themselves actually usually don't know as much as they think they are.
Right. You're right. The more you learn, and the more you experience, and the more you open yourself up to new experiences and new people, it does make you humble, because you realize just how complicated the world is. And you know what it does too, with me, and I think with it makes you less judgmental too. I am less judgmental now than I was when I was in college. I was much more likely to make a quick judgment about someone, or to make an assumption and believe that I knew what it was, that it was sound, whether it was about a situation or a person. And now I'm much more like, my mother used to say this. I was sharing with someone else. She used to say, "You can't judge a book by its cover." It's an old-fashioned kind of, but she really taught me that. And I didn't, as I've gotten older, now I really understand.
That's what she meant.
That's what she meant.
Yeah. So, I think that's great. Well, thank you so much for sharing your story. I really thought that the work that you're doing at ConsejoSano is so important to bring more equity in healthcare to everybody.
Well, thank you, Christine. Thanks for taking the time. I love the conversation, and let me know if I can be helpful to you.
Great. Well, thank you.
Thank you for listening to another episode of the Health Technology Podcast. We want to thank our executive producer, Herminio Neto, our content writer, Casper Mossman, and our podcast engineer, Andrew Rojek. If you enjoyed this podcast, be sure to subscribe and leave a review. The Health Technology Podcast is available on all major platforms.